questions from this topic. Also in your college exam, this is usually a long question or a short note that you get. So I really want you to understand the concept behind shock and the newer modalities and the new developments in this field, because that is a constant question in the entrance exam. Now, the first thing which I want you to know is what is the definition of shock. Now, this you must have covered in physiology as well. And a very simple definition of shock is that it is hypoxia at the cellular level. Right? Hypoxia at the cellular level, and there can be various causes of shock. The first one which we're going to talk about is the most common, that is hypovolemic shock. So hypovolemic or hemorrhagic shock is the most common type of shock. In fact, we say that if a patient presents with shock and you are unsure about the etiology, it is safe to treat it as, it is safe to assume that it is hypovolemic shock. So initially you can assume that the patient has hypovolemic shock and start treating the patient, and then you can work out the etiology if you're unsure what exactly the patient is suffering from. Now, hypovolemic or hemorrhagic shock. If we talk about hemorrhagic shock, it can be of two types. You can either have concealed bleeding. Which we cannot see, or there can be revealed bleeding, which exactly we can measure the blood loss and we can see the blood loss happening. Now, I'll just show you an image to depict the two. This is similar to a case which I saw when I was a first year postgraduate. So there was a chef who was working, and by some mistake, we don't know exactly what happened, but the chef's knife just went through his thigh. And when he came to the hospital, he had this huge gash on the thigh, which was bleeding, and he was actively oozing out blood from there, and spurters there. So you will actually see blood loss happening, and that is blood loss is happening at the patient is in shock. Okay. The other one is concealed hemorrhage. Concealed hemorrhage is when you can't see that blood loss is happening, but it is accumulating somewhere. So what are the sites where blood can accumulate without us coming to know about it or actually seeing the blood loss? So you can have blood accumulation in the thorax, as you can see in this image, in the abdomen, and in the pelvis, and long bones like femur. So these are the concealed areas where blood loss can happen, and the patient can go in shock without actually a single drop of blood being seen outside. Okay. One thing which I want you to remember here, this is very important for the exam. Isolated head injury and isolated head bleed can never give rise to hypovolemic shock. This is a very important statement which I want you to remember. There is not enough space in the cranial capacity in the cranial cavity. Even if there is blood loss, the patient will not develop hypovolemic shock, right? So isolated head injury and isolated head bleed will never give rise to hypovolemic shock. If there is a patient, has head injury and hypovolemic shock, then search for other sites of bleeding. They need to search for other sites of bleeding. Right? And I've told you other sites are going to be, you can either look at the floor if there's blood loss or those concealed areas which I just told you. Right? So this is the first thing which I want you to remember. So another thing which I want you to remember, that bleeding can either happen, it can either be an arterial source of bleeding or it can be a venous source of bleeding. Now, there are two types of injuries. Either there can be transection of the artery or there can just be a laceration of the artery. Now, a question which is asked in the exam, transection versus laceration, which one is going to bleed more? Transected means it is completely cut into two pieces. Transected. Lacerated means there's just a cut over the artery. Now, lacerations of the artery bleed more. They bleed more as compared to transection. Why? Because when it is transected, you must have studied in pathology that whenever there is a vessel injury, the first response is vasospasm. There is spasm of the artery, right? So in transection, the vasospasm will reduce the bleeding. Whereas when there is a laceration, because of spasm, the opening increases. And there is more bleeding. So this is point number one which I want you to remember, that a lacerated artery bleeds more than a transected artery. Now second, venous blood. It is a gradual ooze. So because it is gradual ooze, more time for body to compensate. We'll talk about the compensation when I discuss the parameters of hypovolemic shock, but more time for body to compensate. And because the body can compensate more, these patients with venous bleeding will present. I hope you understand this point. Because there is a gradual ooze, the body's mechanisms, the physiology can recalibrate and can adjust to that blood loss. So patients with a venous ooze will present very late when the BP suddenly drops. Okay, so this is another point which I want you to remember. Now, when we talk about hemorrhage, supposing I'm doing surgery and bleed, that is primary hemorrhage. The second one is reactionary hemorrhage. This is the one which has been asked most commonly, reactionary hemorrhage. Reactionary hemorrhage can occur 4 to 24 hours after surgery. Can occur 4 to 24 hours after surgery. So what are the causes of reactionary hemorrhage? The causes of reactionary hemorrhage would be increase in blood pressure or slippage of the knot. Slippage of knot. In previous modules, we've spoken about surgical knots. Which knot would the surgeon have used which can slip easily? Yes, if you use a granny's knot, then it can slip and to a reactionary hemorrhage. Also, what happens is that supposing when I'm doing the surgery, the anesthetist maintains the PP at a lower range than normal, so that I have a bloodless field when I'm doing surgery. Okay? But if I close at the same low PP, and then the PP rises in the post-operative period, then small oozers and vessels can start bleeding later on. And I would not know about it until unless it manifests in the drain. Okay? Which is why, as a surgeon, before I start closing any wound, I ask the anesthetist, is the blood pressure close to the baseline blood pressure? So I will only start closing when the blood pressure is close to the baseline blood pressure so that I don't miss out on this reactionary hemorrhage. The final type of hemorrhage is secondary hemorrhage. Now, secondary hemorrhage will occur after a few days. And this occurs because of sloughing of the artery. Sloughing of the artery or the vessel, and this can be secondary to infection. It is usually secondary to infection. So these are the three types of hemorrhages which we should know about. So what we've discussed till now, we've discussed that hypovolemic shock is the most common type of shock, and we've discussed what are the various causes that can give rise to it. So this is a very important table that we're going to discuss about hypovolemic shock. And here this is asked in the exam. So what we're going to discuss here, there are 4 classes of hypovolemic shock. So you have class 1, class 2, class 3, and class 4. And the various parameters which we need to discuss in hypovolemic shock are percentage of blood volume loss. This is the most important parameter, percentage of blood volume loss, asked a lot of times. Amount of blood loss. The other parameters which we need to discuss are pulse rate, systolic blood pressure, diastolic blood pressure, pulse pressure. Pulse pressure, you know, is systolic blood pressure minus diastolic blood pressure. You have respiratory rate, urine output, mental status. You have base deficit. Base deficit, I'll tell you what exactly is base deficit. And you have management. So these are the various parameters which we need to discuss in all 4 classes of high school. Hypovolemic shock. Now I know it looks like a lot of parameters, but I'm really going to simplify this table for you, right? And it's very easy for you to understand it. So the first thing that we need to discuss is what is the percentage of blood volume loss in each class of hypovolemic shock. And before I tell you this, I want to show you a video which will clarify a lot of things for you. This is a video which I always show in my class. And this is a video of 2 great tennis players, Federer and Djokovic. This is the US Open finals, right? Federer is the one in red and Djokovic is the one in yellow. And you can see Djokovic has served, and I just want you to see what Federer does in this point. So it looks here as if he's going to lose the point, but he just pulls out an amazing shot. And I want you to watch the slow motion to really understand what exactly did Federer do. And this gave a match point, and he ultimately won the championship. You see here that it looks as if he's losing the point. He just casually runs back and hits the ball between his legs for a winner, right? So between his legs for a winner. Right, so there are a couple of things which I want you to learn from this video. So in the post-match interview, Federer was asked that was it a fluke shot or did you practice this shot quite a lot of times? So Federer said in the post-match interview that it wasn't a fluke. I've practiced this shot more than 1,000 times, right? And he said that the first 200, 300 times I used to get it wrong. But after that, the frequency at which I was getting it right increased tremendously. So one thing which I want all of you to remember is that practice is what is going to make you perfect. If you don't solve MCQs, if you don't practice your MCQs, it will be difficult for you to crack your entrance exam. So keep on practicing MCQs. Yes, initially you will make mistakes, but as you practice them more, you'll get better. Okay? Now the second thing which I want to tell you is that the speed of a tennis game, most of you must be knowing, is 0-0, that is love all. You have 15, 30, 40, and game over. And that is what I want you to remember to memorize the classes of hypovolemic shock. So the classes of hypovolemic shock, very easy to remember. Just remember the scoring of a tennis game, right? So you have 0 to 15%, that is class 1, 15 to 30% is class 2, 30 to 40% is class 3, and game over for the patient, that is more than 40% is class 4. So very easy to remember. Now again, amount of blood loss is at approximately 400 to 500 cc, and you just keep on adding 500 to each class. So this is going to be 1 liter, this is going to be close to 1.5 liters, and this is more than 2 liters, right? So just keep on adding 500, 500 in each class. Now, let's talk about class 1 hypovolemic shock or class 1 hypovolemia. Okay. Now, you have a patient who's lost around 400 to 500 cc of blood. I'm sure a lot of you watching this video must have donated blood as well. And if you donate blood, like I donate blood every 2 to 3 months. My hemoglobin is on the higher side, 17. So the doctors have told me every 3 months I have to donate blood. Okay? So if you donate blood, they take approximately 450 to 500 cc of your blood, right? Now, if you give that much blood, you experience class 1 hypovolemia. Now, blood, what happens to the biomarkers once you donate blood? Well, I don't know about you, but for me, nothing changes. Everything remains normal, right? Nothing changes. Even my mental state is remains normal. The base deficit, you need to understand. Base deficit, that means a deficit in base and excess in acid, right? And when there is shock, there is bound to be acidosis. Okay? But class 1, nothing is changing. So base deficit is also normal. It is 0 to -2. It is 0 to -2 milliequivalents per liter. Okay? And once you've donated blood, what do they give you after blood donation? Well, I fondly remember that you get a fruity and a packet of biscuits. Right? So that's what you get after blood donation. So the management of class 1 hypovolemia is oral liquids. That's all you require. Okay. Let's talk about class 2 shock now. Now, class 2 shock is known as the compensated phase of hypovolemic shock. It is very important. This is the compensated phase of hypovolemic shock. Why are we saying it's the compensated phase? Let's look at the physiology of class 2 shock. So if you look at the physiology of class 2 shock, when there is blood loss, you know that the sympathetic system is stimulated. Like you must have read this in physiology, that the sympathetic system is stimulated. And when the sympathetic system is stimulated, adrenaline and noradrenaline of the system. Now, what is the first change which adrenaline and noradrenaline will bring about? We read this in pharmacology, that the first change which adrenaline and noradrenaline will bring about is tachycardia, or increase in pulse rate. And this is the earliest indicator of hypovolemia. This question is also been asked many times. Earliest indicator of hypovolemia. What else is ADR and NORAD going to do? ADR and NORAD are also going to cause peripheral vasoconstriction. They will cause peripheral vasoconstriction. Now, when the peripheral vasoconstriction happens, that is not going to flow to the periphery. And the peripheries are going to become cold. So you'll have cold peripheries. The hands and legs are going to become cold. So, now, you know that when these arterioles vasoconstrict, what is going to happen to the peripheral vascular resistance? Common sense that if you have a constricted vessel, there is more resistance to the flow of blood to the periphery. Right? Which is why blood is not going into the periphery. So peripheral vasoconstriction will give rise to increased peripheral vascular resistance. PVR is peripheral vascular resistance. So a simple rule of thumb which I want you to remember for all shocks which we discuss later on as well. Any shock with cold extremities, the peripheral vascular resistance increases. And any shock with warm extremities, the peripheral vascular resistance is going to increase. So just remember the simple rule of thumb. Now, why is the body causing peripheral vasoconstriction? Another common sense question. The body is causing peripheral vasoconstriction because it wants that the blood to go to the vital organs, the heart, the brain, and the vital organs, right? So it wants to shunt blood from the peripheries to the vital organs. And that is why this vasoconstriction is happening. This is going to shunt blood to vital organs. And because it shunts more blood to vital organs, the cardiac output and the systolic blood pressure are going to remain normal. Because more blood is returning to the heart, the cardiac output and the systolic blood pressure remain normal, which is why we are saying this is a compensated phase. That despite blood loss, the body has adjusted and there's been no loss in systolic blood pressure. So let's fill out the table now. No loss in systolic blood pressure. let's fill out the table now. We know that pulse rate is increasing. This is the earliest indicator of hypovolemia. Systolic blood pressure is normal. What happens to the diastolic blood pressure? You break physiology. If the peripheral resistance increases, then the diastolic blood pressure will also increase, right? So diastolic blood pressure increases. Now understand one thing. This is a systolic blood pressure, it is remaining normal. This is my diastolic blood pressure. Systolic blood pressure minus diastolic blood pressure is pulse pressure. Systolic is here, diastolic is here. Systolic is not moving, but diastolic is increasing. So if diastolic increases, the distance between the two increases. So the pulse pressure is going to become narrow. The pulse pressure becomes narrow. Okay? Respiratory rate is going to remain the same. The output is normal or slightly reduced. The mental status, patient is going to be thirsty and anxious. Patient is going to be thirsty and anxious. And the base deficit is going to be -2 to -6 milliequivalents per liter. So some amount of acidosis has started happening now, right? So -2 to -6 milliequivalents per liter is the base deficit. And these patients are going to require IV crystalloids. You know crystalloids, I discussed in the chapter in nutrition and fluid about crystalloids, and we can use normal saline or ringer lactate for crystalloids to manage this thing. Now, class 3 shock is the decompensated phase of hypovolemic shock. This is the decompensated phase of hypovolemic shock. What do we mean by the decompensated phase? That now the body has lost so much of blood that now the systolic blood pressure cannot be maintained. So now systolic BP will start to fall. Okay, because body has lost so much of blood. So what is going to happen here? That there's going to be further tachycardia. Tachycardia increases, right? Systolic blood pressure now starts to fall. This is again a very, very important MCQ. In class of hypovolemic shock, does systolic blood pressure fall for the first time? Class 3 shock. Okay, the systolic BP falls for the first time in class 3 shock. Remember that thing. The diastolic blood pressure also falls. Why? Because there is loss of circulatory volume. So although there is vasoconstriction, so the peripheral vascular resistance is increasing, but now because so much of blood is lost, and now diastolic blood pressure will also fall. So the pulse pressure becomes even narrower because now both are falling. So the pulse pressure becomes even more narrow. Respiratory rate is going to increase. Patient will have tachypnea. Urine output now starts to fall dramatically. Okay? And this patient is now confused. Patient is now confused. And the base deficit is -6 to -10 milliequivalents per liter. -6 to -10 milliequivalents per liter. Now these patients cannot be managed alone with crystalloid. So they have to be given IV crystalloid plus colloids. And colloids, I showed you in that table in the chapter on fluids, you can give extra, various types of colloids can be there. But so class of patient, you can give blood products as well, right? So we'll give crystalloids and colloids, and crystalloids to colloids are given in a 3:1 ratio. 3 parts of crystalloids to 1 part of colloids. So class 4 shock is also very easy to remember. The patient has lost so much of blood that everything is non-recordable, right? So you will have pulse rate is non-recordable, right? You have pulse rate non-recordable, you will have BP non-recordable, you can't record the pulse pressure. The respiratory rate increases more. The patient has anuria, no urine production is there. This patient will be in a state of coma, and it will be more than -10 milliequivalents per liter. The base deficit is more than -10 milliequivalents per liter. Right? So these are the 4 classes of hypovolemic shock. And in this patient, the class 4 hypovolemic shock, what do? We have to give these patients massive blood transfusion. We have to give these patients a massive blood transfusion. And I'm going to talk about massive blood transfusion in a few minutes' time. Very important topic, a pet favorite for the games and the Central Institute exam. But class 4 shock patients require massive blood transfusion. Okay, so this table is very important for you to understand. I try to simplify it as much as I could to you. One question here so that you understand what are the practical questions are asked from this table. So let's look at this question now. You have a 70 kg man who's come to the emergency following a stab injury to the abdomen, right? His pulse rate is 110, which is tachycardia, and BP is 90/60. Means systolic is also falling and diastolic is also falling. And he appears confused. What percentage of blood volume has he lost? So very simple. How do we approach these questions? There is tachycardia here, right? So it cannot be class 1 shock. Has to be either class 2, class 3, or class 4. Right? First thing. Second thing, systolic BP has started falling. It is 90 systolic. So systolic BP has started falling. So when does systolic BP fall for the first time? In class 3 shock. Why is it this class 4 shock? Because it's still in the pulse. It's still going to be not right? So this would be class 3 shock. And class 3 shock. Again, remember the scoring of a tennis game? Class 1 was 0 to 15, class 2 was 15 to 30, class 3 was 30 to 40%. So 30 to 40% blood loss has been there this person, and the patient is suffering from class 3 hypovolemic shock. So these are the kind of practical questions which can be asked from the table which we just discussed. So we've discussed the classes of hypovolemic shock and have broadly outlined the sequence for you. Now it is also very important that such patients should be monitored at a regular basis. So how do we monitor a patient with hypovolemic shock? That's a very important concept for you to understand. Now there are two common questions, and these two questions have been asked at least 20 times in your exam. The first question is, which is the best indicator to determine amount of fluid required? Best indicator to determine amount of fluid required in shock, right? And the second question is, which is the best clinical indicator? Which is the best clinical indicator of fluid resuscitation? Of fluid resuscitation in shock. Okay. Now, what is the literal meaning of these two definitions? The first question is asking that when a patient comes to the emergency, how do I determine how much fluid to give to that patient, right? Of shock. How much fluid is to be given, which is that? And the second question is that once I have given fluid to this patient, how do I know whether that was adequate fluid or inadequate fluid? So I hope you've understood the two questions. Now, the first question is how to initially determine how much fluid to give. There the answer is pulmonary capillary wedge pressure is a better answer than CVP. This is pulmonary capillary wedge pressure. And CVP, all of you know, is central venous pressure. So for all practical purposes, it is the central venous pressure which is what we use to determine how much fluid to give. But theoretically speaking, pulmonary capillary wedge pressure is a better answer than CVP because it gives you an accurate indicator of the left-sided heart pressures. Whereas CVP is giving you an indicator of the right-sided heart pressure. Okay, so theoretically, pulmonary capillary wedge pressure is a better answer. Otherwise, for practical purposes, it is CVP. And pulmonary capillary wedge pressure, you know that we use a Swan-Ganz catheter, and then we measure the pulmonary capillary. So this question has been asked many times. You should remember this. Now, once you have given fluid, how do you know whether that fluid has been adequate or inadequate? So that is determined by the urine output. That is determined by the urine output. Very important question. These two questions have been asked at least 20 times in the exam. So you should read the question carefully and then answer after assessing what is the examiner trying to ask you. Okay. Now, the urine output for adults, in a patient with shock, the urine output for adults should be maintained more than 0.5 ml per kg per hour. Whereas for children, our aim should be that it should be more than 1 ml per kg. Now, in addition to this, there are certain new endpoints of fluid resuscitation as well. These have been listed in Bailey, and they're very important for the exam, asked a lot of times in the last couple of years. So what are the new endpoints of resuscitation? The new endpoints of resuscitation for systemic perfusion. So for systemic perfusion, the new endpoint of resuscitation, which you need to remember for your exam, is MVOS. This is mixed. I'll talk about this in detail in 2 minutes. Mixed venous oxygen saturation. The second one is base deficit, which I've already told you is because there is acidosis. And the third one is serum lactate. So these are the three for systemic perfusion. These are the new endpoints. And if you have to choose the single best endpoint of resuscitation, it is MVOS. Right? So for any future exam, if they ask you which is the best endpoint of fluid resuscitation, you will also mention there, you have MVOS also mentioned there. You will mark this. Right? That is the single best endpoint of resuscitation. If they ask clinical endpoint, you will mark urine. Okay? So please no confusion there. For muscle perfusion, and for brain perfusion, it is the same. For muscle perfusion and brain perfusion, the endpoints of resuscitation are NIRS, that is the near infrared spectroscopy. NIRS is near infrared spectroscopy, and tissue oxygen electrode. So these are the two endpoints of resuscitation for muscle and brain perfusion. For gut perfusion, there are three of them: sublingual capnometry, gut mucosal pH, and laser Doppler flometry. Okay, so you have sublingual capnometry, gut mucosal pH, and laser Doppler flometry. You have to remember these endpoints. This is a table directly from Bailey, but please remember that MVOS is the single best endpoint of resuscitation. One more thing which I want to tell you here, and I've covered this in the stomach module as well. Mucosa. That the gastric mucosa is the most sensitive mucosa. It is the most sensitive mucosa in GIT to hypovolemic insult. So whenever there is a hypovolemic insult in the body, it is the gastric mucosa which is sensitive. Right? What is the practical importance of this? Because the gastric mucosa is more sensitive, that is why you can get stress ulcers. Whenever there is hypovolemic shock, patient can develop stress ulcers, and then so these two types of stress ulcers which are discussed in both upper GI and Burns module are pushing and curling ulcers which develop in a stressful condition. So this is how we monitor a patient with hypovolemic shock. Before I move further and tell you more in this, let me tell you about MVOS. What exactly is MVOS? So this stands for mixed venous oxygen saturation. Right, so this is the amount of oxygen which is returning back to the heart after being utilized in the body. That is MVOS. So let me simplify this for you further. So supposing 100 molecules of oxygen are pushed from the heart into the body, right? The body wants to utilize this oxygen. So supposing the body utilizes 50 molecules of oxygen and 50 molecules are returning back to the heart. So that is the MVOS. The percentage of oxygen which is returning back to the heart is mixed venous oxygen saturation. Right? So accurate measure of MVOS can be done by drawing blood from a catheter in the right atrium. That is going to give you the accurate measurement. Why not the SVC? If blood is drawn from the SVC, if blood is drawn from the superior vena cava, then you can get an inaccurate measurement. Why? Because there is more oxygen extraction, because more oxygen extraction occurs in the lower limb. So you will get a false value here, falsely high value, because more extraction is happening from the lower part of the body or the lower limbs. So for accurate measurement, it should be from the right atrium. Now the normal value of MVOS is between 50 to 70%. That is the normal value of MVOS. Less than 50% MVOS, where are we going to get less than 50% MVOS? That's a common sense question. One is if the heart is pushing less oxygen, right? Or the second is if the body is utilizing more oxygen. Those are the two situations when you're going to have a low MPOS, right? So low MPOS will be seen in patients with cardiogenic shock because the heart is unable to pump out oxygen, and you will have it in hypovolemic shock. Why in hypovolemic shock? Because I told you there is peripheral vasoconstriction, right? Excess of blood which is happening, and because the circulating blood is less, there is less oxygen which is being sent. So because less oxygen and stasis is there, the body extracts more oxygen. The tissue is going to extract more oxygen, and less oxygen is going to return. So that also leads to a low MPOS. So these are the two types of shock where you can get low MPOS. Now, where will be seen in patients with septic shock. Why septic shock? Septic shock, we are going to discuss later. The warm phase of septic shock is a hyperdynamic phase. Right? Warm phase and a hyperdynamic. So because there is a hyperdynamic phase, there is quick circulation. Quick circulation is there. And this leads to less extraction of oxygen. Also, there is impaired tissue oxygen extraction in septic shock. Impaired tissue oxygen extraction. So these two reasons lead to a high MPOS in patients with septic shock. So I've told you what is MPOS. I've told you the causes of low and high MPOS. This you should remember for the exam. So even in distributive shock, right? Distributive shock like anaphylactic shock and neurogenic shock also, you can get a high MPOS. Because there also the same thing is happening. Gases of blood, so more oxygen is being extracted. So this was regarding MPOS. Now there are certain indices which I want you to remember in our exam. These are also used to monitor shock. One is shock index. The first index which I want you to know is the shock index. Shock index is heart rate by systolic blood pressure. The other one is modified shock index. The other one is modified shock index. Modified shock index is heart rate divided by mean arterial pressure. Mean arterial. Third one is ROPE. ROPE stands for rate over pressure difference. Stands for rate over pressure difference. That is ROPE. So rate means heart rate and pressure difference. What is pressure difference? Systolic minus diastolic is pulse pressure. So heart rate by pulse pressure is ROPE. Now out of these three, modified shock index is the most sensitive indicator. Modified shock index is the most sensitive indicator. This point has also been asked in the exam. Another thing which I want you to remember is that a shock index, if you have a shock index ratio of more than 0.9, then there is higher mortality. This is very important. This is from a large scale study which was done, and it's found out that if shock index is more than 0.9, higher mortality. If the ROPE value is less than 3, patient remains stable. But if ROPE, that is rate over pressure difference, is more than 3, then it is indicative that the patient might develop decompensated hemorrhagic shock. So if you can, for the Central Institute exams, please remember these two values. Shock index of more than 0.9 and ROPE of more than 0.3. So I've told you various things how to monitor hypovolemic shock. Now, I have to discuss a very important point, that is massive blood transfusion. Now, I have to discuss a important point, that is massive blood transfusion. Massive blood transfusion, you need to remember for the exam because almost each year there is a question which is being asked from this topic. First, what is the definition of massive blood transfusion? That is when we replace the entire circulating volume in 24 hours. That is number one. Or if more than 10 units of blood, are given in 24 hours, that is number two. And number three is if more than 4 units of PRBC or blood product are given in 1 hour. So these are three definitions which you need to remember for massive blood transfusion. The definition itself has been asked many times. Now, to know when such large quantities of blood is required, there has to be a protocol. So there is a massive blood transfusion protocol which is initiated whenever we anticipate that a patient would require such large quantities. Okay? Before I joined my post graduation, I had done an internship at Cornell. I was at a level 1 trauma center in Bronx. Now, Bronx is one of the areas in New York, but it is notorious for crime, right? And that level 1 trauma center was in the middle of that high violence zone. And every time I was informed, could hear what that outside. So one such patient landed up to with 4 gunshot wounds to the abdomen, right? And the patient had non-recordable vital signs when the patient came in. The patient was resuscitated and we activated the massive blood transfusion protocol. In 24 hours, this patient was given 14 lakhs of blood products. Okay? So classified as massive blood transfusion. Now, when you such large quantities of massive blood products, there are found to be certain complications as well. So what are the complications of massive blood transfusion? The complications of massive blood transfusion, you know that blood that gets from the blood is cold, right? Transfuses 1 unit of blood. We can take our own sweet time for the blood to come to room temperature and then we start transfusing. I'm sure all of you have done that. But in patients where we are in a hurry, we have to transfuse 10 units in 24 hours or 4 units in 1 hour, then we don't get blood, right? So in these patients, when we are giving blood so rapidly, these patients can become hypothermic. They can be hypothermia. Now, you also know that when you give blood, flowing blood, it has an anticoagulant. The anticoagulant used is citrate. So citrate is the anticoagulant which we are using these days. And because citrate is going to chelate calcium and magnesium, these patients can develop hypocalcemia and hypomagnesemia. Hypocalcemia. Now, don't think there is 80 ml of citrate which is there. This 80 ml of citrate is normally metabolized by a normal person like us can metabolize it in 10 minutes. But patients who are in shock cannot metabolize the citrate effectively. So massive blood transfusion can also give rise to citrate toxicity later on. This can give rise to citrate toxicity later on and it can worsen the metabolic profile of the patient. What happens to potassium? So potassium, you can either have hyperkalemia or there can be hypokalemia. Why? Hyperkalemia because you know that stored RBCs can lyse. Stored RBCs can lyse. And when stored RBCs lyse, potassium is released. Also later on when there is acidosis, that can also increase the potassium. Hypokalemia, why? Because RBCs after transfusion can actively, because the RBCs after transfusion can actively take in potassium and that can right. There can also be metabolic alkalosis initially. Why would there be metabolic alkalosis? This is due to citrate toxicity. Citrate metabolism is going to give rise to metabolic alkalosis, but later on this is then metabolic acidosis. So both alkalosis and acidosis, later on there is acidosis. Of course, you can have the blood transfusion reactions which are there because we are giving so much of blood. The blood transfusion reactions, which are the febrile reactions, you can have febrile reactions which are the most common, and rarely you can also have an anaphylactic reaction in mismatched blood transfusion. Other problems which can happen in these patients, there are 2 terms which I want you to know. These 2 terms have also been asked in the exam in the last 2 years. TACO and TRALI. What is TACO? TACO is transfusion associated. TACO is transfusion associated cardiac overload. Transfusion associated cardiac overload is TACO, and TRALI is transfusion related acute lung injury. transfusion-related acute lung injury is chronic. Now, as interns I'm sure you people must have transfused blood to patients, and sometimes you must have transfused 2 or 3 units as well. Sometimes what happens when you transfuse blood, there can be a volume overload. And how will that volume overload manifest in the patient? That volume overload will manifest as puffiness of the face, and these can be signs of cardiac overload. And this will develop as you are transfusing blood. Within some time of that only you will notice these changes. And I'm sure all of you must have seen that when you notice these changes, your senior comes and your senior says, when this is due to fluid overload, what do we need to do here? We need to give this patient Lasix, right? This patient diuretics or Lasix, and that is going to take care of this problem. So diuretics are to be given if you have TAFE. TRADI, on the other hand, is transfusion-related acute lung injury. Now, TRADI usually develops within 6 hours of transfusion. Within 6 hours of transfusion, you are going to have TRADI, and it is hypothesized that this is due to anti-HLA antibodies, and this is going to give rise to a picture of ARDS, acute respiratory distress syndrome, right? Acute respiratory distress syndrome in medicine in great detail. So you have chest infiltrates, saturation would be low. But the good thing is that if TRADI is detected early and treated adequately, so these 2 terms you need to remember, TAFO and TRADI. One final point regarding massive blood transfusion, the most common cause of death in massive blood transfusion, this question has been asked multiple times, is coagulopathy. It is not TRADI, it is coagulopathy. So why is coagulopathy occurring in these patients? Coagulopathy is occurring because of hypothermia. You remember the chapter of trauma where I've spoken about abdominal trauma, I've spoken about damage control surgery. Then I told you the terrible triad of trauma. The terrible triad of trauma is hypothermia, acidosis, and coagulopathy. So all 3 are related. Right? The other cause is, as I mentioned, it will be acidosis. And the most important thing is dilutional coagulopathy is there. There is dilutional coagulopathy. What do we mean by this? We know that the blood which we are transfusing is stored blood is poor in, not rich in platelets, and it has decreased clotting factor. So there can be dilutional coagulopathy. Now, how to deal with this problem of coagulopathy in massive blood transfusion? So to deal with this problem, the massive blood transfusion protocol, and this has also been asked 2 or 3 times, is that the ratio of PRBC to FFP to platelets in massive blood transfusion should be 1:1:1. So PRBC is fat RBCs is fresh frozen plasma. FFP is fresh frozen plasma. And so the ratio should be 1:1:1 when we are doing massive blood transfusion in order to avoid coagulopathy. Now, these blood products, their storage, how do we transfuse them, has been covered in great detail in pathology by Dr. Dilla in the blood banking module, right? I want you to listen to that module along with the shock module because those values are asked in the exam. The reason why I don't want to tell you the values here because we compared and the values in baby and the values in Robert are different. And blood banking is a standard book for blood banking. So Dr. Dilla has covered values from that standard book. So I want you to remember those values rather than the ones which are mentioned in C. So this is how we prevent coagulopathy. Now another thing which I want you to know here, there are two scores which are for massive blood transfusion. These are scores which help in taking decisions regarding massive blood transfusion, especially in trauma patients. You have the ABC score. It has three parameters: penetrating trauma mechanism, systolic BP less than 90, heart rate more than 120, and positive fast. The CAT score, you need to remember the full form of CAT score. It is trauma-associated severe hemorrhage score, and it has 7 parameters in it. These two scores have not been asked in the exam as of now, but I just want you to remember the name and the full form of CAT. You also need to remember about the form of CAT. You also need to remember about blood substitutes, right? Sometimes we don't get blood. Supposing you know that we are in a very tricky situation with China right now, and it is in a place like where you have, if there is going to be a fight, so in places like those, you need to have blood substitutes also to maintain the patient's life till you can shift the patient to the hospital. So these blood substitutes, you have first generation substitutes like first fluorocarbons, second generation are stroma-free hemoglobin, and the next generation which is being evaluated these days is polyethylene glycol hemoglobin. Hemospan. Hemospan, a lot of trials have been done in Hemospan. This is PEG conjugated human hemoglobin, and you have pyridoxylated hemoglobin, polyoxyethylene conjugate, PHP. This is also being evaluated. So I just want you to remember the names. Again, this has not been asked in the exam till now. Also told you about this anti-shock garment when I was talking about pneumatic anti-stockings. I told you about the anti-shock garment as well. You have numbering from 1 to 6, and this is being used in patients with hypovolemic shock. So where do we use it? Supposing you have a lady who has delivered in a primary health center and she starts having postpartum hemorrhage. Now the primary health center is not well equipped to manage this postpartum hemorrhage, and you need to take the patient to the hospital, but the hospital is 1 hour away. So of course you want to give fluids to the patient, but you'll also tie this garment. And this garment has a sequential compression, maximum compression here and least compression here as we go up. So what this does is that this squeezes out blood from the limbs and sends it to the heart so that the blood pressure can be maintained for some time till the patient is shifted to the hospital. So this was regarding massive blood transfusion. Another thing which I want you to know, there are some key definitions which I want you to remember in hypovolemic shock. One is occult hypoperfusion. This is a new term which is there in daily, and you need to remember this. So occult hypoperfusion means that the patient is going to have normal cardiovascular parameters. Patient is going to have normal cardiovascular parameters. That means pulse rate, BP. Patient is going to have normal urine output. Normal urine output, but is going to be low MVOS and acidosis. So this is the preclinical state of hypotension. This occult hypotension, where the parameters are normal, your cardiovascular and urine output, but there is low MVOS and there is hypotension. This is parameters, that means pulse rate, BP. Patient is going to have normal urine output. Normal urine output, but there is going to be low MVOS and acidosis. Right? So this is the preclinical state of hypotension. This is occult hypotension, where the parameters are normal. Your cardiovascular and urine output, but there is no MVOS and there is acidosis in this patient. Now, what is the importance of occult hypoperfusion? That if occult hypoperfusion, if it lasts for more than 12 hours, then there is a poor outcome. So we need to identify occult hypoperfusion early and we need to manage it on time. What is dynamic fluid response in shock? So any patient with shock, we discussed that we have to give fluids to these patients. And patient with shock, we give a bolus of fluid. We give a bolus of fluid. Perfusion early and we need to manage it on time. What is dynamic fluid response in shock? So any patient with shock, we discussed that we have to give fluids to these patients. And patient with shock, we give a bolus of fluid. We give a bolus of fluid, which is 250 to 500 cc bolus we give as soon as we get this patient. And the normal response after giving this is that the CVP increases by 2 to 5 centimeters of water. CVP rises by 2 to 5 centimeters of water. And it gradually normalizes. It gradually normalizes in 20 minutes or so. So this is normal response. Now, there are three types of responses in a patient with shock. You can have responders. Once you give this fluid, you can have responders. Responders, I just told you that there will be a CVP rise and it will then normalize, like I just told you. Then you have non-responders. Non-responders, when there is no change. And you can have transient responders. And you can have transient responders. Transient responders will show a rise in CVP, will show rise in CVP, but CVP again returns to pre-treatment value. That means again low CVP in 10 to 15 minutes. So initially they show a spike, they show increase, but then it returns to the pre-treatment value in 10 to 15 minutes. So responses which we can get when we give fluids to a patient of shock. How does this help me as a clinician? Non-responder means that the patient is losing so much of blood that the rate at which I'm giving is not able to match with the rate of loss. So we need to evaluate what is the cause of loss and we need to treat that. Transient responder means that there is ongoing losses happening. So again, these patients we need to monitor carefully and we need to identify the cause and treat that as well. So these are the three types of responses we can get in a patient with shock. Another important update in the 27th edition of Bailey is that the perioperative blood transfusion guidelines have been changed. Perioperative transfusion means after surgery, if a patient is given blood or not given blood, those are now determined by these guidelines. And you need to remember this is very important, that if the hemoglobin is less than 6, if the hemoglobin is less than 6, then there is going to be benefit from transfusion. If the hemoglobin is 6 to 8, only give blood. We only give blood if ongoing losses are there. If ongoing losses are present, then only we give blood. And more than 8, there is no indication of giving blood transfusion if the hemoglobin is more than 8. So please remember these parameters. One point I want you to know, this was after the AIIMS exam a couple of years back. When we are giving blood, there is a special filter which we can use here. This is known as a leukoreduction filter. This is a leukoreduction filter. Again, the details have been covered in the blood banking module by Dr. Ella. So leukoreduction filter, it reduces the incidence of febrile reaction. It reduces the incidence of febrile reaction. So this takes care of hypovolemic shock. It is a very, very important topic. So we've already discussed hypovolemic shock. Hypovolemic we've already discussed. The other type of shock can be cardiogenic shock. So this is related to cardiac causes. Another very important one is neurogenic shock. This has also been asked in the exam quite frequently. You have anaphylactic shock, and you have septic shock. Septic shock, you know, is divided into a warm septic shock. Two more terms which you need to know. You can have obstructive shock. This I'll cover in some time. You can have distributive shock. After making this table, I'll cover these two terms. And the third one is endophthalmic shock. So these are three more types of shocks. I'll tell you about them once I make this table regarding these 5 types. And the various parameters which we need to consider in this table are pulse rate, cardiac output, systolic blood pressure, JVP, JVP is jugular venous pressure, and peripheral vascular resistance. First, let's write peripheral vascular resistance and JVP. PVR is peripheral vascular resistance, JVP is jugular venous pressure, or the CVP, central venous pressure. Now, hypovolemic shock we've already covered, and we are assuming that we have a patient in class 3 hypovolemic shock. We are assuming a patient in class 3 hypovolemic shock. Let's fill in the blanks. We know that there is going to be tachycardia. And class 3 hypovolemic shock, the cardiac output is going to fall. Cardiac output falls, and we know that systolic blood pressure also falls for the first time in class 3 shock. Now, we've discussed that the extremities are going to be cold. Right? Why do we have cold extremities? Because there's peripheral vasoconstriction. And when there is peripheral vasoconstriction, what will happen to the resistance? So the peripheral vascular resistance is going to be. Please don't get confused. Yes, initially peripheral vascular resistance rise is going to give rise to increase in diastolic blood pressure. But as the blood volume loses from the body, as the blood volume is lost from the body, then the diastolic blood pressure is also going to fall. Okay. JVP also falls because there's loss of circulating blood volume. So these are the parameters for hypovolemic shock. Cardiogenic shock, there can be multiple causes of cardiogenic shock. You can have myocardial infarction, you can have arrhythmia, you can have tamponade. There can be various causes of cardiogenic shock. We can consider anyone. Let's consider a patient who's had a myocardial loses from the body. As the blood volume is lost from the body, is going to give rise to increase in diastolic blood pressure. But as the blood volume loses from the body, as the blood volume is lost from the body, then the diastolic blood pressure is also going to fall. Okay. JVP also falls because there's loss of circulating blood volume. So these are the parameters for hypovolemic shock. Cardiogenic shock, there can be multiple causes of cardiogenic shock. You can have myocardial infarction, you can have arrhythmia, you can have tamponade. There can be various causes of cardiogenic shock. We can consider anyone. Let's consider a patient who's had a myocardial infarction. So when there is a myocardial infarction, the cardiac output is reduced. The heart is not working properly. Because the cardiac output is reduced, the systolic blood pressure is reduced. And because the cardiac output is reduced, blood is not flowing to the extremities properly. So the extremities are cold. Extremities are cold. There is vasoconstriction in the extremities. So because there is vasoconstriction, there is increase in peripheral vascular resistance, which is there. And also need to remember that because the heart is not working, the cardiac output is low. The preload is the which is there, the heart is to pump out, right? So the preload is accumulating, and this leads to increase in JVP, and you have important dilation. So this is regarding cardiogenic shock. If you have to fill in the table now, pulse rate can either be increased or decreased. Why? Because in arrhythmias, you might have a high heart rate, whereas if there is a patient who has a heart block, which can also give rise to cardiogenic shock, there will be bradycardia. You can either have cardiac output is going to reduce, systolic BP is going to reduce, extremities are again cold, so peripheral vascular resistance increases, and because the heart is not pumping out blood, there is raised JVP in God's state. Moving on to very important neurogenic shock. Neurogenic shock has been asked almost the same number of times as hypovolemic shock. Now, neurogenic shock, we are going to consider the example of a transected spinal cord after a road traffic accident. In the trauma module, I told you that cervical spine is very important for us. If there is a cervical spine injury, that can give rise to spinal shock. There can be transection of the spinal cord, and it can give rise to neurogenic shock. So here, I just want you to remember one thing. If you just remember this one term, the entire physiology will become very easy for you to understand. And that one term is that when the spinal cord is transected, there is loss of sympathetic tone. Just this one term is enough to understand the physiology. When there's loss of the sympathetic system or loss of sympathetic tone, you know what is going to happen. There is going to be vasodilation is going to be there, right? You're going to have vasodilation. These patients are also going to have bradycardia. Yeah, because there is loss of sympathetic tone, so there is going to be bradycardia. That means the heart rate is low, and there is vasodilation in the periphery because the sympathetic tone has low. Now, when there is peripheral vasodilation, the extremities are going to be warm because there's more blood accumulating there. So you have vasodilation, warm extremities, and this is going to give rise to pooling of blood. Why is there pooling of blood? Because that patient is lying on the ground after the accident. His spinal cord is transected, cannot move. The blood is there in the periphery, but the blood is not returning back. The blood is not returning back. So there is pooling of blood. There is decreased venous return. Now, if there is decreased venous return, common sense question: what is going to happen to the preload? The preload is going to reduce. So decreased JVP because less blood is returning. Decreased JVP, decreased preload means decreased cardiac output, which means decreased systolic blood pressure. So this is the physiology behind neurogenic shock, right? Let's put it now in the table. So neurogenic shock, you can see there is bradycardia occurring, cardiac output is also reducing, systolic BP is also reducing, peripheral vascular resistance is reducing. Why? Because the extremities are warm, and JVP is also falling because the return is less. So all the parameters have reduced. And the question that has been asked umpteen number of times is bradycardia and hypotension are seen in which shock? They are seen in neurogenic shock. They are seen in neurogenic shock. Please don't confuse this with bradycardia and hypertension, which is seen in head injury. Bradycardia, hypertension, and head injury is Cushing reflex. I covered that in the head injury module, right? Don't confuse that with neurogenic shock. Neurogenic shock is brady and hypotension. Let's talk about anaphylactic shock now. Anaphylactic shock, we are going to consider the example of a mismatched blood transfusion. Right? So anaphylaxis, you can have mismatched blood transfusion. Now, when there is a mismatched blood transfusion, histamine is released, and histamine is the driver for this anaphylaxis and anaphylactic shock. You know, large quantities of histamine are released. Now, I want you to very carefully observe what is happening in this shock, okay? And this is a correlation which I want you to understand. So, when histamine is released, you know, histamine is a potent vasodilator, right? Potent vasodilator. So, look carefully. Vasodilation, this is going to give rise to warm extremities. This will again give rise to cooling of blood. Again, give rise to decreased venous return. Again, give rise to decreased JVP. Again, decreased cardiac output, decreased systolic blood pressure. So, the story is exactly the same as neurogenic shock. But what is the difference here? But sympathetic system is normal. Sympathetic system is normal. Therefore, pulse rate is going to increase. So everything is the same as neurogenic. The only difference is that there is going to be tachycardia in anaphylactic shock. It is the same as neurogenic. So easy to remember. Anaphylactic shock, tachycardia, rest everything reduces as neurogenic. septic shock. Septic shock, you have two phases of septic shock. So in the warm phase of septic shock, I just want you to remember one term. The term which I want you to remember in warm septic shock is hyperdynamic circulation. It is hyperdynamic circulation. That is the only term which I want you to remember in warm septic shock. So what is happening? The heart is working quickly. When you have fever, there is tachycardia. Heart is working quickly. Blood is quickly going through the body and coming back. Right? So blood goes quickly, comes back quickly. There is a hyperdynamic circulation which is there. So there's going to be tachycardia. There's going to be tachycardia. Because the heart is working overtime, then its cardiac output is going to be increased. So when the cardiac output is increased, systolic blood pressure will also be increased or normal. Right? Extremities are warm. It's there in the shock itself, warm extremities. So warm extremities means peripheral vascular resistance is low. Extremities are warm. And what is happening to the JVP? So understand this. This is very important. Whatever the heart is pumping out, it is coming back, and again the heart is pumping back. Right? So pump comes back, pump comes back. It pumps again. There is no backlog which is occurring here. Right? No backlog of preload. So JVP is normal. JVP is normal in this case. Okay? This is warm septic shock. Cold septic shock, I want you to remember that in late phases of sepsis, what happens? Bacterial toxins inhibit the myocardium. The bacterial toxins inhibit the myocardium. Therefore, late septic shock or cold septic shock is equal to cardiogenic shock. So the parameters of cold septic shock are exactly the same as cardiogenic shock. So this is another easy correlation for you so that you can remember this for the exam. Now these three terms which I mentioned, obstructive, distributive, and endocrine shock, what exactly do these mean? First, let's talk about obstructive shock. So obstructive shock by definition is a shock in which the preload. So obstructive shock by definition is a shock in which the preload is reduced due to mechanical impairment in cardiac filling. Due to mechanical impairment in cardiac filling. Right, so what exactly does this term mean? Let's consider examples of obstructive shock. You can have cardiac tamponade. Cardiac tamponade is covered in the thoracic trauma module. Cardiac tamponade, you know that there is rapid accumulation of blood around the heart. And because of this, the heart cannot relax. If the heart cannot dilate or relax, filling will not happen, right? And if filling does not happen, cardiac output will not get generated. Okay, so this is one example, cardiac tamponade. Another one is a massive pulmonary embolism. a massive pulmonary embolism is also going to hamper cardiac filling. And when cardiac filling gets hampered, the cardiac output and the systolic blood pressure reduce. So this is obstructive shock. Distributive shock. So distributive shock is when the blood redistributes to the peripheries, when the blood redistributes to peripheries, thereby reducing cardiac output, right? So when there is more blood which accumulates in the peripheries, less blood is coming back to the heart, and that is going to give rise to shock. So what are the examples of distributive shock? They are going to be neurogenic, you will have anaphylactic, and you will have warm septic shock. So all the three shocks in which the extremities are warm, they classify as distributive shock. So easy way to remember. Any shock with warm extremities is an example of distributive shock. And endocrine shock. Endocrine shock can be a combination of distributive and hypovolemic and cardiogenic shock. Right? It can be a combination of these shocks, and endocrine shock you can get in hyperthyroidism and adrenal problems, and in patients with adrenal problems. Okay? So these are three more definitions which you should know, and this covers the various types of shocks which you need to know for the exam. Now we are going to talk about septic shock in detail because that is a very important topic for the exam. So we'll talk about sepsis. So there are certain definitions in sepsis and septic shock which are asked frequently in the exam. The first one which you need to know is SIRS. SIRS stands for Systemic Inflammatory Response Syndrome. It is Systemic Inflammatory Response Syndrome. In simple terms, what is this? In simple terms, this is the body's response. This is the body's response to inflammation. It is the body's response to inflammation. Now, this inflammation can either be infective or non-infective. So it can be secondary to infection, or it can even be secondary to trauma. So it's not necessarily that it's all because of infection or sepsis only. This is mediated by IL-1, IL-6, and TNF-alpha. Mediated by IL-1, IL-6, and TNF-alpha. These interleukins have been asked in the exam, which control the SIRS response of the body. What are the parameters? The parameters are temperature less than 36 degrees centigrade or more than 38 degrees centigrade. WBC count less than 4,000 or more than 12,000. or more than 10% band forms in peripheral smear. This last one is something which students forget. So please make sure you don't forget this. This has been asked in the UPSC exam many times. Third parameter is respiratory rate more than 20 per minute or PCO2 less than 32 millimeters of mercury. Right? The final parameter is pulse rate more than 90 per minute. So these are the four parameters which you need to remember regarding SIRS. So these are the four parameters which you need to remember regarding SIRS. And if any two parameters are met, then we say that the patient is having SIRS, systemic inflammatory response syndrome. What are the other definitions? The other definitions are sepsis. So sepsis is SIRS plus a known site or known foci of infection. Means supposing if somebody has a boil and that boil is giving rise to SIRS, then we'll say that the patient has sepsis because the patient has parameters of SIRS, but the cause is that boil. So we are going to say that the patient is in sepsis. Septic shock. Septic shock is sepsis plus hypotension. Sepsis plus hypotension, which fails to respond to fluids. Which fails to respond to fluids. That is septic shock. MODS. Multiple organ dysfunction syndrome. Multiple organ dysfunction syndrome. So MODS is when there is failure of two or more two or more organ systems. That is when we say the patient has MODS. This has a high mortality rate. Now, one thing that I want you to understand is that kidneys will be one organ system. It's not as if one or both kidneys have failed, so you won't count as two organs. So kidneys would be one organ system. The respiratory system would be another organ system. Cardiac would be another organ system. CNS would be another organ system, right? So if there's failure of two or more organ systems, we label it as MODS. So these are certain definitions that you need to remember. Now, there are certain new updates regarding sepsis, and those updates I want you to know. The first update is this SOFA score. This is the sepsis related organ failure assessment score. This is the SOFA score. And if you have a SOFA score of 2 or more than 2, plus known foci, then we call it sepsis. A SOFA score of 2 or more than 2 plus a known foci of infection would classify as sepsis. But what you need to understand here is that this SOFA score is such an elaborate score that it becomes difficult for us to measure each and every parameter. So to circumvent that problem of having so many parameters, we've also come out with a SOFA score. What is QSOFA? This is quick sequential. This is quick sequential organ failure assessment score. Quick sequential organ failure assessment score is QSOFA. And what are included in QSOFA? You have systolic TP less than 100, altered mental status, and tachypnea more than 22. Please, don't get confused. Here, tachypnea is more than 22, but in SIRS, tachypnea guideline was more than 20. So they're different. Don't get confused between the two. Now, if you have a score of 2 or more than 2, it indicates a poor outcome. So you need to remember QSOFA, you need to remember the parameters. In the last 4 years, there have been 6 questions in various exams regarding QSOFA. This is very, very important for your exam. So sepsis 3.0, these are the latest guidelines. What are the updates which you need to remember? The definition of sepsis now has changed. One definition I've told you is SOFA score of 2 or more than 2 plus known foci of infection. Another one is life-threatening organ dysfunction caused by a dysregulated host response to infection, right? So that is another definition of sepsis. Septic shock, the definition has changed, very important. It is the need for vasopressors and serum lactate more than 2 millimoles per liter. Serum lactate of 2 millimoles per, more than 2 millimoles per liter. The term severe sepsis has been removed and SIRS is out and QSOFA and SOFA are used. One more thing, this is not there in Bailey, but it's there in Sevistan, the surviving sepsis. guidelines, and you had a question in the NEET exam last to last year from the surviving sepsis guidelines. Now, these guidelines say that within the first 6 hours of resuscitation of a septic patient, we need to achieve all these goals. What are the goals which we need to achieve in a patient with sepsis who's undergoing resuscitation? We need to get a CVP of 8 to 12 millimeters of mercury, a mean arterial pressure of more than equal to 65 millimeters of mercury, urine output of more than equal to 0.5 ml per kg per hour, and MVOS, mixed venous oxygen saturation, of 65 or more. I told you sometime back that MVOS in sepsis is increased, and we have to maintain it that way so that adequate oxygen reaches the tissues. So the MVOS in sepsis should be kept between 65 to 70. Okay. Also, we need to normalize lactate in these patients. Now, if you have a patient with septic shock, first give fluids. We have to first give fluids, and if they are not sufficient, then we can start the patient on inotropes and vasopressors. Like you can start the patient on dopamine, nobutamine, noradrenaline, but all of these are started only once the patient has failed on fluid resuscitation. Okay. So this is the management of septic shock. I've told you the definitions which are important for the exam, and this brings us to the end of this module. I've told you time and again that this module is very, very, very important from the point of view of all exams. Before we end, let's just solve few MCQs. So which one of the following is C? in massive blood transfusion. Now, I told you that both metabolic alkalosis and acidosis can be seen, but what is more important and more common is metabolic acidosis. So if you're given a question like this, you will choose metabolic acidosis. The capillary refill time is prolonged in all types of shock except, right? So capillary refill time prolonged. When will capillary refill time be prolonged? When there is vasoconstriction and less blood is flowing, or when there is vasodilation and more blood is flowing? Of course, when less blood is flowing, that is when capillary refill is going to be delayed, so or prolonged. So that is going to happen in hypovolemic shock. It's going to happen in cardiogenic shock. Obstructive shock, you know, is a type of cardiogenic shock only. So here you will have cold extremities, cold extremities, cold extremities. So the capillary refill time will be prolonged. Septic shock, you know, you have warm extremities. So here the capillary refill time will not. This is another practical application of that table which we have discussed. You have a 26-year-old man with road traffic accident. He had a pelvic fracture and was transfused blood. Within a few hours, the patient develops fever, polyuria, and hypotension. CVP is normal, but there is bleeding from the side of the IV line through the Ryle's tube. What is the most common diagnosis? This was asked in the AIIMS exam. Fat embolism, you know, can occur after a long bone fracture, but it occurs after around 24 to 48 hours. So this is out. Adrenal insufficiency, there's no indication that this patient might have adrenal insufficiency. Hemorrhagic shock. If there was hemorrhagic shock, CVP, how will CVP be normal? For CVP to be normal, cannot be hemorrhagic shock. In hemorrhagic shock, CVP or JVP will be reduced. We've discussed this. So this is also out. So even by elimination, we can reach to blood transfusion reaction. But the classic keyword here, which is a throwaway that it is a blood transfusion reaction, is that there is bleeding which is happening from the IV line, from the right tube. So there's coagulopathy which has started happening. And you can see this is a direct picture from Bailey, where if antibodies are present in incompatible transfusion, this is going to result in acute hemolytic reaction. So hemolysis is what is happening there, and that is what is giving rise to the transfusion reaction in this patient, which is not a complication of massive blood transfusion. So we know hyperkalemia can occur, we know hypocalcemia can occur, we know hypokalemia can occur. So hypercalcemia will not occur. Okay, this was another question asked in the exam. Right. In hemorrhage, larger arterioles vasoconstrict in response to the sympathetic nervous system. Yes, that is why there are cold extremities when there is hemorrhage. Which categories are associated with vasodilation of large arterioles? So don't get confused by such technical questions and technical terms. Try to simplify it for yourself. Okay? The examiner is saying that in hemorrhagic shock, there is vasoconstriction. So the extremities are cold. Now he's asking which are the shocks where there is vasodilation. So if there will be vasodilation, extremities are going to be what? Extremities are going to be warm. So which are the shocks where extremities are warm? You have septic shock, neurogenic shock. So the answer becomes A and C. Following a recent abdominal surgery, the patient is in the ICU with sepsis. Below what level of hemoglobin would a transfusion be indicated? I've told you that transfusion now is indicated when it is 6 or close to 6. That's when you're going to do transfusion. If it's 6 to 8, then there has to be ongoing losses. Then only we transfuse. Okay. So this is a very important question. This is where you're given a clinical scenario, and these are the options which you have to choose from. Whether the patient has SIRS, sepsis, MODS, septic shock, or severe sepsis. So let's look at the statements and see what the patient has. You have a 44-year-old male. He has an ideal perforation. On the third postoperative day, he has pain, and an ultrasound reveals that there has been a leak. So there is a leak after surgery. There has been a leak. His pulse rate is 100 per minute, tachycardia. BP is 100 by 80. WBC count is 15,000. Respiratory rate is 20 per minute. The urea is 70, creatinine is 1.5. He is conscious and oriented but complaining of pain. So what does this patient have? Okay, let's start step by step. Like I told you the definitions. Does this patient have SIRS? Yes or no? Let's see. His counts are raised and his respiratory rate is more than 20. So two parameters are met. Yes, he has SIRS. Now, does he have a foci of infection? That is the next question I need to ask myself when I'm approaching such questions. Yes, he does have a foci of infection. There is an ileal perforation leak which has occurred. After repair, there has been a leak. So I know that SIRS plus foci is equal to sepsis. So this much I know that this patient is having sepsis. Does he have MODS? Does he have MODS? You know, MODS is failure of 2 or more organ systems. So if you look here, his kidneys, urea is 70. Kidney function is deranged. Kidneys are gone. So one organ system is gone. But he is conscious and oriented. So CNS is intact. So only one organ system is affected here. So does he have MODS? No, he does not. So what is the answer here? The patient has sepsis. I hope this is clear because you can expect many more questions like this in your next exam, in your INI CET exam. You will be shown clinical vignettes like this and you'll be asked questions. And I've just told you the approach to such questions. Okay. Let's look at another patient. We'll follow the same approach. You have a 65-year-old diabetic patient who's been brought with Fournier's gangrene. Fournier's gangrene, you know, is necrotizing fasciitis of the perineal region. The pulse rate is 110. So tachycardia, BP is 90 systolic. BP is also falling. On giving fluids, BP does not improve. Okay. He started on dopamine, noradrenaline, and debridement is planned. His liver functions are marginally deranged, but other blood parameters are normal. So let's do the same analysis as we did here. Does this patient have SIRS? Yes. Why? Because there's tachycardia and there is hypotension. So two parameters are met. Yes, he has SIRS. Does he have a known foci of infection? Yes, he has Fournier's gangrene. So he has SIRS and he has Fournier, so he has sepsis. This must also be known. Is there septic shock? Is there septic shock? Well, there is hypotension and it does not improve with fluids, So yes, there is septic shock in this patient. Is there MODS? No, there is no MODS because only his liver functions are deranged. The rest of the parameters are normal. So here the answer is going to be septic shock. So you can see different clinical scenarios and how have we utilized the definitions which I told you to answer these clinical scenarios. This is very important for your future exams. This brings us to the end of this very important module on shock.